So coming to the skull and pelvis, common definitions. These things are asked in the examination. Lie. The lie refers to the relationship of the long axis of the fundus to the long axis of the centralized uterus or the maternal spine. The commonest lie being longitudinal in 99.5% of cases. So this also you should know how many percent of cases we get a longitudinal lie in 99.5% of cases. And lie is the relation between the long axis of the fetus with the long axis of the maternal spine or the centralized uterine axis. Okay, the lie may be transverse or oblique. Sometimes the lie is unstable until the labor sets, when it becomes either longitudinal or transverse. Okay, so that is what is the lie. Okay, 99.5% cases you will have this longitudinal lie. Okay, these are the other types of lie. Then presentation, the part of the fetus which occupies the lower pole of the uterus, that is the pelvic rim, is called as the presentation of the fetus. It is cephalic in 96.5% of cases. Sometimes they ask these percentages. Okay, so lie is a longitudinal in 99.5% of cases, while cephalic presentation is 96.5% of cases. Podiatric breach is around 3%. That we know that term breach incidence is around 3%. Shoulder and other will be, all presentations will contribute only 0.5%. Okay, so this becomes 96.5 plus 0.5 will become 97, and the rest will be the breach. Okay, when more than one part of the fetus present, it is called as compound presentation. Okay, coming to the presenting part, the presenting part is defined as the part of the presentation which overlies the internal os and is felt by the examining finger through the cervical opening. Cephalic presentation, the presenting part may be vertex, that is commonest, then brow or face depending upon the degree of flexion of the head. Okay, so longitudinal lie we have seen 99.5% of cases, and only in 0.5% you have the transverse, oblique and unstable. Okay, presentation is cephalic in 96.5% of cases, 3% will be breech and shoulder will be 0.5%. Then presenting part cephalic, vertex is seen in 96% of cases, and brow and face in 0.5% of cases. That is the presenting part. Okay, then coming to the attitude. The attitude is the relation of the different parts of the fetus to one another, is called as the attitude of the fetus. The universal attitude is that of the flexion. Okay, so everywhere at all joints you get the flexion, including there is a flexion at the level of the neck also. The head is completely flexed, and accordingly you get the diameter. Okay, so well flexed head, you have the 9.5 centimeter AP diameter. In vertex, which is deflex, you will have 11.5. Brow you will have 14 centimeter. This is these are all SBAs. Okay, face they can ask you vertex, or they can ask you this brow also, and this is present in occipito-posterior position also. Okay, 11.5 centimeter. Then denominator, it is an arbitrary bony fixed point on the presenting part which comes in relation with the various quadrants of the maternal pelvis. The following are the denominators of the different. So we have the occiput in vertex, mentum or chin in face, then frontal eminence in brow, sacrum in breech, and acromion in shoulder. This is also SBA. They have asked in the past, what is the denominator in brow presentation? What is the denominator in shoulder presentation? Okay, so you should know occiput is in vertex presentation, mentum is in face presentation, then brow we have the frontal eminence, and sacrum in the breech, and shoulder presentation we have the acromion. So these are the denominators. Then coming to the position, it is the relation of the denominator to the different quadrants of the pelvis. Okay, so wherever this denominator lies, you will accordingly you will have the left occipito anterior, right occipito anterior, left occipito, right occipito posterior, left occipito posterior. So these are the four positions of the vertex. Okay, so the first vertex is the vertex occupying the left anterior quadrant of the pelvis. That is the commonest one, left occipito anterior, followed by the right occipito anterior. So they may ask you what is the commonest, that is left occipito. Second common will be the right occipito. So anterior is more common than the posterior. That is how you remember. So in anterior also left will be common, followed by the right anterior. So left anterior, right anterior. Then comes the right posterior, and then comes the left posterior. Okay, because left side there is a sigmoid column, so left posterior will be the least common. Okay, that is the fourth position. Okay, then coming to the engagement, when the greatest horizontal plane, that is the biparietal, has passed the plane of the pelvic brim, the head is said to be engaged. This is what we know. Okay, then we also know about the fetal skull. This is actually all anatomy we have studied in the MBBS as well as in our MS curriculum also. Okay, so the parts, this we know, this is the coronal suture, the part which lies between the glabella or the root of the nose and the this to the anterior fontanelle is the sinciput. Here is the vertex between the lambdoid suture and the coronal suture, and posteriorly we have the occiput. Okay, so vertex is a quadrangular area bounded anteriorly by the bregma and coronal sutures, and behind by the lambda and lambdoid sutures, and laterally by the line passing through the parietal eminences. Okay, so these sometimes they ask you the diagrammatic questions. So they'll give you the diagram and they will label this as X, and this X is labeled, they may label this as X, and this X is labeled, suppose this is anterior frontally, they may label this as X, and X is dash, denotes dash dash. Okay, so you should remember these particular image questions also. Okay, vertex, it is a quadrangular area bounded anteriorly by the bregma and coronal sutures, behind by the lambda and the lambdoid sutures. Okay, so here you have the coronal sutures and the bregma anteriorly, and lambdoid suture and the lambda posteriorly, laterally by the line passing through the parietal eminence. Bro, it is an area bounded on one side by the anterior fontanelle and coronal sutures, and on the other side by the root of the nose and the supraorbital ridges. So root of the nose and the supraorbital ridges on this side, and here by the coronal sutures and the bregma you have the bro. Okay, so that corresponds to the area of the sinciput also. The face, it is an area which is bounded on one side by the root of the nose and the supraorbital ridges, and on the other side by the junction of the floor of the mouth with the neck. So from here on, here onwards, the face will start. Okay. Then sinciput is the area lying in front of the anterior fontanelle and corresponds to the area of the brow, and occiput is limited by the occipital bone. Okay, so these areas, this is actually all we have studied, but these questions and the diameters they ask you in the examination. Fontanelles is the wide gap in the suture line. That is what is the fontanelle. Of these fontanelle, there are total 6 in number. There are 2 are of obstetric importance. One is the anterior fontanelle, that is called as a bregma, and second is the posterior fontanelle, also called as lambda. So anterior fontanelle, it is formed by joining of the 4 sutures in the mid plane. The sutures are anteriorly frontal, posteriorly sagittal, and on either side you have the coronal. Okay, between the frontal and sagittal, and on either side coronal. So that will form the this anterior fontanelle. It is diamond shaped. So this is very important. There is a SB on this. Okay. They can ask you about the shape. It is a diamond shape. Its anteroposterior transverse diameter is 3 centimeter each. The floor is formed by the membrane and it becomes ossified at 18 months. This is also SBA. The anterior fontanelle becomes ossified at what age? 18 months after the birth. It becomes pathological if it fails to ossify even after 24 months. Okay. So when does it ossify? It ossifies at 18 months. Then posterior fontanelle, it is formed by the junction of the 3 sutures. Okay, sagittal sutures anteriorly and lambdoid suture on either side. It is triangular in shape and measures around 1.2 by 1.2 centimeters. So anterior we have seen 3 centimeter in both directions. Here it is 1.2 by 1.2 and it is triangular in shape. Okay. First, its floor is formed membranous and it becomes bony at term. Okay, that is what is the difference between the anterior and posterior. It is bony at term itself. Thus, truly nomenclature as fontanelle is misnomer. It denotes the position of the head in relation to the maternal pelvis. Okay. Then coming to the sagittal fontanelle, they are inconsistent and not very clinically significant. Okay. So, and various diameters are there. Let me see if I can enlarge this for you. These diameters, are you able to see these particular diameters or you are not able to read? I think you are not
I'm
able.
not able to read.
Yeah.
This is very
Yeah.
confusing.
Actually, I'm not able to magnify this, but this is same what we have studied. No, it is same. I'll try if I can magnify this. Let me see from where I can. I can magnify this. No. Anyway, see. I'll describe from this here only. Okay, you have a suboccipitobregmatic
Okay, sir.
extends from the nape of the neck to the center of the bregma. Okay, from the nape of the neck to the center of the bregma. That is, this is the suboccipitobregmatic. Okay, in the vertex presentation, you get well flexed vertex. You have 9.5 centimeter suboccipitobregmatic. Okay, then you have suboccipitofrontal. Suboccipitofrontal. Okay, it extends from the nape of the neck to the anterior end of the anterior fontanelle or center of the sinciput. Okay, this is occipitofrontal and this is the suboccipitobregmatic and this is the suboccipitofrontal. So this is the suboccipitofrontal. This is the occipitofrontal. Suboccipitobregmatic, suboccipitofrontal, and the occipitofrontal. Okay. So from the occiput, you have two diameters. One goes to the center of the bregma and one goes here. That is the center of the sinciput or the anterior end of the anterior fontanelle. So this is the suboccipitobregmatic, then this is the suboccipitofrontal, and from occiput to the this root of the nose will go is a occipitofrontal. Okay, so we know that list is 9.5, so this is 9.5. This will be slightly larger, 10 centimeter, and this is occipitofrontal, which is present in the which presentation? Occipito-posterior presentation, which is 11.5. Okay, this also you should remember in which position it is present. Occipito-posterior position. This is the diameter of engagement, which is around 11.5 centimeter. List normally is suboccipitobregmatic, 9.5 centimeter. Okay, if it is a slightly deflex, it will be suboccipito frontal. Okay, and completely flexed, it will be suboccipitobregmatic. And if it is a deflex, then it will become a occipitoposterior and it will be occipitofrontal diameter. Okay, so 9.5 centimeter, 10 centimeter, and 11.5 centimeter. Very only three figures are there. And remember, list is a 9.1. In face also, you have got two dimensions, this diameters. So go from here. Submentobregmatic extends from the junction of the floor of the mouth and neck to the center of the bregma. This is the suboccipito submentobregmatic. Okay, this is again list, that is 9.5 centimeters. So we have two. One is in the face presentation, that is submentobregmatic. This is suboccipitobregmatic. Both are 9.5. Okay. Okay. And then we have submentovertical. Okay. Submentovertical. This, I don't think they have shown here submentovertical. Okay. They have shown mentovertical directly. Okay. This mentovertical is, we know that it is present in the bro presentation. Okay. This bro presentation is the largest diameter, which is around 14 centimeter. Okay. And submentovertical extends from the junction of the floor of the mouth and neck to the highest point on the sagittal suture. So from here, actually it should go like this. This is not there here. Okay, but they can ask you this 9.5 face, they can ask completely flexed will be suboccipitobregmatic, completely deflex will be occipitofrontal, and face will be submentobregmatic. Okay. Bregmatic. Okay. And longest will be the mentovertical, which is in the mentovertical. Okay. Then transverse diameter. In the transverse diameter, we have BPD, which is 9.5 centimeter, which extends between the two parietal eminences. Super subparietal is 8.5, that is between the point below the parietal eminence to the opposite side at the level of the parietal eminence. Okay, that is super subparietal 8.5. This has not been asked, but BPD has been asked, 9.5 centimeter. Then between the two this bitemporal diameter, distance between the anterior inferior ends of the coronal suture, that is bitemporal diameter 8 centimeter. Then you have bimastoid diameter, which is 7.5 centimeter. The distance between the tips of the mastoid process, the diameter is incompressible and it is impossible to reduce the length of the bimastoid diameter by any obstetrical operation. So bimastoid also you should remember, because it is the least diameter, 7.5 centimeter, and this bimastoid you cannot reduce by any maneuver. Okay, so if your this bimestral cannot pass through the pelvis, definitely it is going to be the severely contracted pelvis. Okay, see this bimestral is a 7.5 centimeter, biparietal 9.5 centimeter, and bimestral 7.5 centimeter. Okay, and rest are in between. You have bitemporal and super subparietal. Okay, super subparietal is actually one side, it is below the parietal eminence, opposite side to the parietal eminence. It is something like that. So between 9.5 it becomes 8.5, and the 8 becomes bitemporal, distance between the anterior inferior ends of the coronal suture. This bitemporal also not been asked, but bitemporal bimestral you should remember. Okay, now we'll cover the molding. We know molding is asked in the examination. After molding, we'll stop. Okay. So it is the alteration of the shape of the forecoming head while passing through the resistant birth passage during the labor. Very little alteration of the size of the head, as volume of the content inside the skull is incompressible, although small amount of CSF and blood escape out in the process. During normal delivery, an alteration of 4 millimeter in the skull diameter commonly happens. So less than 5 millimeter molding is normal. What is the mechanism? There is a compression of the engaging diameter of the fetal head with corresponding elongation of the diameter at right angles to it. So if the head gets compressed in this direction at right angles to it, there will be elongation. That is what is the mechanism. So it will get compressed along the diameter of the engagement, and at right angles to it, there will be elongation. In a well-flexed head, the anterior vertex presentation, the engaging is a suboccipitobregmatic. That is the commonest what we have seen, 9.5 centimeter diameter is compressed with the elongation of the head in the mento-vertical diameter, which is at right angle to the suboccipitobregmatic. This is what we have seen. This is the suboccipitobregmatic. So right angle to it, it is a mento-vertical. So when this gets compressed, there will be elongation in this direction. That is what they want to say. Okay. So during the process, the parietal bones tends to overlap the adjacent bones, like occipital bone behind, the frontal bones in front, and the temporal bones at sides. In first vertex position, the right parietal bone tends to override the left one, and this becomes reverse in second vertex presentation. Molding disappears few hours after the birth. Okay, so it will disappear. This is one of the differentiating features. Sometimes they can ask you the difference between the molding and caput. Okay, or this uh, then types of molding. Importance: slight molding is inevitable and beneficial. It enables the head to pass more easily through the birth canal. Extreme molding, as made in the disproportion, may produce severe intracranial disturbance in form of tearing of the temporal cerebelli or subdural hemorrhage. Shape of the molding can be useful information about the position of the head occupied in the pelvis. So slight molding is inevitable and beneficial, but if it is extreme, then it can cause the tears in the tentorium cerebelli, or it can lead to the subdural hemorrhage. Okay. Another is a caput succedaneum. It is the formation of the swelling due to the stagnation of the fluid in the layers of the skull beneath the girdle of the contact. So when the head is prolonged in a one particular position, then below the girdle of the contact, you get this caput succedaneum. The girdle of the contact is either bony or dilating cervix or vulval ring. The swelling is diffuse, boggy, and is not limited by the suture line. It may be confused with the septal hematoma. It disappears spontaneously within 24 hours of the birth. So caput also disappears within 24 hours of the birth. So this caput we have to differentiate from the cephal hematoma. That is what is the actually they ask you, not this molding. Okay, molding they can ask the how much is physiological and okay. So this what is the mechanism of formation of this caput? While the head descends to press over the, just a moment. While the head descends to press over the dilating cervix or the vulval ring, the overlying scalp is free from the pressure, but the tissues in contact with the full circumference of the girdle of contact is compressed. This interferes with the, basically there is a blockage of the venous return and lymphatic drainage from the unsupported area of the scalp, leading to the stagnation of the fluid and appearance of the swelling in the scalp. Caput usually occurs after the rupture of the membrane. Okay, what is the importance? It signifies the static position of the head for a long period of time. Location of the caput gives an idea about the position of the head occupied in the pelvis and the degree of flexion achieved. In the left position, the caput is placed on the right parietal bone, and in the right position, it will be on the left parietal bone. With increasing flexion, the caput is placed more posterior. Okay, so this is what is the today's session.